Okay, welcome everyone. I am Jamie Hadley. I am the Director of Communications for the Pause Life, and we are here with Dr. Vonda Wright and Dr. Mary Claire Haber. I will introduce them each in just a moment and then give you a little bit of information about how you'll be able to ask questions, and then we'll turn it over to them. Dr. Vonda Wright. At 40, Dr. Wright was in the best shape of her life. At 48, she thought perimenopause might be killing her. Relatable. Thankfully, she's learned how to master midlife and menopause, spending her time educating the 51% of the world born with ovaries and the people who love them. How to make the rest of our life the best of our life at the intersection of aging and midlife, menopause, and mobility. Dr. Wright is a double-boarded orthopedic sports surgeon, entrepreneur, author, speaker, and innovative leader focused on optimizing personal and professional performance at every age. Dr. Wright has served as the inaugural medical director and chief of service in several large health systems, building comprehensive programs and departments de novo, and is an internationally recognized authority on active aging and mobility, caring for active people, athletes, and executive performers of all ages and skill levels. In addition to her surgical practice, Dr. Wright is the founder of the nonprofit Women's Health Conversations and membership community, Ageless.life, that's AJLES.life, and has written 5 books, speaks worldwide, and is a media content expert, regularly appearing on national TV shows, print and digital media outlets, and hosts her own podcast, Hot for Your Health. Dr. Wright received her medical degree from the University of Chicago, Pritzker School of Medicine, served her residency in orthopedic surgery at the University of Pittsburgh, and her fellowship at the prestigious Hospital for Special Surgery in New York. Dr. Wright currently lives in Lake Nona, Florida, with her husband, 2-time Stanley Cup champion, Peter Taglianetti, and their blended family of 6 children, 2 old dogs, and her 84-year-old parents. Thanks for being here, Dr. Wright.
Thank you for reading all that.
I figure they need to know as much about you as possible.
Yeah, I think it's important, and that really what a world now renowned expert you are in this.
Absolutely.
Case.
Oh, well, I'm honored to be in your presence. And you know what? I feel like Mary Claire, Dr. Mary Claire. Can I call you Mary Claire for the purposes of this?
Yeah.
You know what? I've known you forever from afar, but I was so thrilled to finally go on a walk and spend time with you in New York just a month ago. It's really funny how a common passion brings people from different parts of the country together. Mm-hmm. And so I'm so thankful to be here.
I'm so glad we've, have so much interest in what your area of specialty is from our followers, from our listeners, and not only the people who are joining us live today, but all of the people who are going to watch this on replay and learn how to advocate for themselves even better. So, so let's get started.
Let's make one.
Sorry.
While Dr. Haber and Dr. Wright are both doctors, they are not your doctors and unfortunately cannot answer your personal medical questions, but they will aim to arm you with the best information that will help serve you in speaking with your doctors. If you have questions, the Q&A is open. I will be monitoring that throughout. In the meantime, Dr. Haber and Dr. Wright will be discussing some common issues associated with musculoskeletal health in menopause, and we'll ask some of your questions in the last 10 to 15 minutes. So I will turn it over to the 2 of you.
Okay. So Dr. Wright, tell me, your menopause story. 40 years old, best shape of your life. You're doing massive athletic events. You're killing it. You're also taking care of whole sports teams, if I remember correctly. And all of a sudden at 48, by then the switch had flipped for you. Let's walk me through your experience.
You know what?
Resonate with so many people.
Right. Don't judge me when I say this out loud. Yeah, all those things about 40. I had my only biologic child. We're a blended family, right? So I had 5 teenagers and a new baby at 40 and all that kind of stuff going on, and then building a new career. Mary Claire, please forgive me when I say out loud at 48, I did not know that the heart palpitations that sent me racing to my cardiologist to get on a stress test could be the same thing happening with the massive hemorrhagic periods I was having after being an athlete my whole life. I would go like 6 months with nothing. I'm like, well, I'm not pregnant, but right. So to suddenly have that going on, I honestly said to myself, Mary Claire, wow, at 48, I'm finally a woman. I'm finally having regular periods. That is how little I knew about what was going on with the night sweats. I knew night sweats. You can't get away from having that, knowing that that's part of it. Or sticking, we call it in our house, the thermometer leg sticking out the bed, right? But the thing that hit me in one of the biggest ways, other than hemorrhagic periods and thinking my heart was exploding, my entire body hurt. I could barely get out of bed. And I had never felt my body. I'm used to really having a responsive body. I could, if I noticed I was gaining weight, I could just be more mindful and it would come off. I mean, I only say that in the most loving way because I know some women can't do that, but I had no idea. And when I talked to a girlfriend of mine about these hemorrhagic periods, she didn't know either. And we're both surgeons. So if we don't know, what do we expect the public to know? So I got really busy and I got Estrogen Matters and I started investigating because I refuse to be anything except what I'm capable of. And so I just did a deep dive to learn and figure out everything I needed to address so that I don't suffer in misery. I don't think midlife has to be misery. So that I can master this in the same way. I don't know, you and I figured out how to study in medical school. We have figured out a lot of stuff.
Yeah.
For me, it was just another thing to figure out. And so that's what I call my menopause story. Like, I knew I was aging. I'm an aging researcher, but I did not know what was hitting me. And thank God I do now, and I figured it out.
So, I was similar. I was going through a big grief process with the loss of my brother, and I was really attributing, and I had gotten off of contraception to kind of see where I was at hormonally. So I was, naked. Yeah, I was on my own hormonally outside of pregnancy for the first time since I was 16. And, I'm barely functioning from depression. I'm just getting up to scrape myself together to get to work. I'm not paying any attention to nutrition. I have no energy to exercise. I can barely talk to my children. And the whole time I'm like, it's grief, it's grief, it's grief. And then, the weight gain, I was like, well, you're eating too much, you're not working out. Okay, fine. I deserve this. And then the grief fog starts lifting, but I'm still not sleeping, having horrific, disrupted sleep, still exhausted during the day, and I'm starting musculoskeletal stuff. And I'm like, God, why am I still so depressed? I mean, like, I'm not, and literally, I'm an OB-GYN. This is my job. And I'm like, when was my last period? Like,
yeah,
oh my God, I think I'm in menopause. And then I felt like I was like menopause had such a negative connotation to me.
Right.
That I was instantly depressed, like almost like I got diagnosed with diverticulitis or one of these old lady diseases, like nothing wrong with diverticulitis, and I'll probably have it one day, but I just was like, ugh,
you never thought it would be you. Or maybe I never thought I'd go through it. I don't even know why I was in such a fantasy.
And I thought I'd be one of those girlies who would just breeze through it. It would not be a big deal. And, maybe a hot flash here or there, but not knowing I would be brought to my knees. From it. Now, you mentioned Estrogen Matters. Tell everyone what that is.
Yeah. So I was trying to figure out all the mythology that surrounds estrogen replacement therapy, or HT, as we now say, hormone therapy. And I didn't know where to turn. I had one of the best OBs in Atlanta, but it just wasn't a common thing to present in a cogent way. So I don't know how I found them. I think I found them on the internet. Estrogen Matters is a book by Avram Blooming and Carol Tavris. Avram Blooming is an oncologist. Carol Tavris is a social scientist, and she is just witty and smart. And together they put together the world's research on hormone therapy, the risks of various diseases. And, you know, Carol will say things like, I'm making this up, but it's this outlandish. I mean, it's this level. You have more likelihood of being hit by an airplane than dying from estrogen, blah, blah, blah. So they really boiled it down. And so I now recommend it. In addition to you, I recommend menopause.org. I recommend Estrogen Matters to everybody walking in to my life, including 3 people in my orthopedic clinic today, because we have to be in control of the information.
Mhm.
Other people do not get to tell us what to do, who we are, because we are just lazy, right? So we need to go seek the info, and Estrogen Matters is a great place to start. I started on Audible, and then I needed to underline stuff because that's the way I learned. So I bought the hard copy. But I guess what I'm saying is seek out the information and the trusted sources so that you are not swimming in a morass of mythology.
So talk a little bit about, and we'll get into the specifics of the musculoskeletal part, but talk a little bit about, you know, we get a lot of people like, I shouldn't have to do this. Like, I should be able to walk into my doctor's office with a list of symptoms, you know, and walk out with a plan, and I'm getting nothing. I'm being told I'm being dismissed. I'm being told it's psychological. I'm being told this is normal. I'm being told, and I'm not any better. I don't feel better. And so why do you think this is happening?
Well, number one, I get enraged when women write me, as I'm sure they write you, about how gaslighted and how dismissed, and the actual words that are said to them by their physicians. And I publicly say to physicians, okay, people, we can do better. We are the helping occupation. We can do better. Given I know doctors are tired. We have to see too many patients, right? So number one, I don't think it's acceptable. Number two, you've stated this. There's great data that shows that less than 25% of any doctor in any school, good school, meteor school, any medical school gets a menopause education. In fact, I ask my medical students at University of Central Florida, where I mentor kids, they just had their OB, the third years had their OB rotation, how much time they spent on midlife and menopause, and literally it was 3 hours. So it's 30 years or 40 years of a woman's life, right? So I think there are all those things. I think the Gen Xers, which is you and me, are going to change it for the millennials and for the Zs. The millennials don't take crap. Listen, I'm going to give you an example. When I was coming up in my surgical practice, I was still taking my boards. I had this new baby. I was nursing her. There was no accommodation for nursing a baby during 10-hour boards. So milk's everywhere, right? There were no accommodations for Gen X. But do you know that the millennials coming up behind me are not taking it? And I feel, and they've gotten all kinds of accommodations, and rightly so. So I feel like as the generations turn, it will get better and better for women, but it does not excuse women for taking control of their own health. And if you're not getting what you want, find another doctor.
Yeah, I agree. So what is the musculoskeletal syndrome of menopause? I know.
Yes. Yeah.
So let's go through that.
I love that you said those words, because it's a nomenclature that I'm actually making up, and it's after the gynecourinary syndrome of menopause. The Pfizer, the 5 or 6 things that we know are directly affected by estrogen levels. And so the musculoskeletal syndrome of menopause, when estrogen declines, and the 5 things that I kind of I've adopted within this are inflammation shoots to the sky due to the role of estrogen on the immune system and the inflammasomes and the role of estrogen and beta receptors. We decrease the production of a stem cell in our muscles called satellite cells, right? Satellite cells are the cells that, and if you follow me on Instagram, I've put little cells from my lab up there. They're dancing in a petri dish. They are what reproduce new muscle for us, and we must do so a lot across a health span. Without estrogen, we can lose 20% of our lean muscle mass and our strength, not just the size, but the capacity of muscle to contract together. Of course, everybody knows that estrogen is critical for bone density, and that 50% of all fractures happen in women after 50, and 70% of all hip fractures, which is, listen, this happened. I was on call last week. People fall down from a standing position in their kitchens. It's not like the truck ran over them. Their bone breaks and they fall down, right? It's always a question, what happened first, the bone break or they fell and then the bone breaks? And then finally, I do also adopt, although many disciplines can claim it, the increase of visceral adiposity, fat is I put it in the musculoskeletal basket. But those things alone are directly related to the drop in estrogen. And the thing that's important about this, one of the many things is, and don't throw eggs at me, people, but hot flashes, night sweats, brain fog tend to go away with time.
Mm-hmm.
The musculoskeletal symptoms of menopause are silent, potentially devastating, and permanent, unless somebody tells you that you're going to lose 20% of your bone density and you show up at 65 for a DEXA scan when your insurance will pay for it with a -3 T-score. So, I mean, I think we don't even know. Our bones are silent until they break. Our muscles are silent until we notice that we'd have no muscle mass left, right? So
Right.
it's an extreme awareness thing we need to build.
So how would you suggest, like, would you suggest someone paying out of pocket for I know I checked before this, here in Houston, you can get a bone density scan at a local like shop that just does these as part of like wellness for $99.
Exactly. There's a place like that in Lake Nona, Florida called Apex Fitness. They bought a top of the line DEXA scanner that you would find in a hospital. And I take all my clients over there because I want to know their adiposity. I want to know their bone density. I want to know their lean muscle mass. And I say things like, listen, don't pay for accessories, pay for your bone density, or, you know, a purse isn't going to help you, but a bone density will. I just think we have to prioritize.
So, how many women do you think are affected by this, by the musculoskeletal syndrome of menopause? Like what percentage?
Yeah. Their data, many of the studies are actually from India and Israel, but not so many in the United States. I hope that changes. But up to 80% of all women will expect the musculoskeletal symptoms of menopause, and 25% will be devastated by it, but they won't know why.
So the studies I've seen are the musculoskeletal are the most bothersome in about 20% of women, you know, and meaning that they're devastated.
Yeah.
So what really opened my eyes to it, I mean, we've known about osteoporosis forever, and that was an old lady disease, you know, in my mind, this whole like old lady thing. Well, now that I am an old lady, it's a lot more serious now, but you know, 50% of women will fall and have a fracture, or not even fall, will have an osteoporotic fracture.
Mm-hmm.
I mean, and if it's your hip, 30% will die even with surgery in the first year.
That's true.
And this is preventable. This is all preventable.
You know what, Mary Claire, I had a 28-year-old in my clinic with a hip fracture because she had been amenorrheic. She had been an athlete. 28. I had a 57-year-old who was doing everything she thought she should be doing, lifting heavy weights. She wasn't eating enough. She was kind of starving her muscles. Broke her hip. I think it's silent. We don't see our bones. We don't even notice, right? Everybody, go look at your clavicle right now. Just even notice you have a bone, right? We take them for granted because they just hold our clothes up, right?
Right. So when we talk about the different, you know, we have muscle, we have bone, we have tendon, we have cartilage. Can you talk about each of those units and how they're affected by our decreasing estrogen levels?
I want to start with cartilage, because cartilage, for those who may not be aware, cartilage is the smoother than ice end cap of all bones. It's literally like a bumper. It's about 6 millimeters thick. And when it goes bad, That is arthritis. Loss of cartilage, whether it's traumatic, whether it's wear and tear, like osteoarthritis, or whether it's rheumatoid, like an autoimmune disease, is loss of cartilage. Here's what we know. Before 50, men have a higher rate of developing arthritis. After 50, when estrogen walks out the door, women's rate of osteoarthritis rapidly increases. That's because every musculoskeletal tissue has estrogen alpha and beta receptors, which are like little baskets sitting up on the cell surfaces. And when estrogen sits inside of them, all these beautiful downstream pathways happen. And so when these are empty, when it comes to cartilage, the cartilage matrix weakens and softens. And women wear their cartilage away faster. For a tendon, we know that the natural history of tendon and ligament is for the bonds to become tighter and tighter and tighter and tighter with time, and they become more brittle. And so without estrogen, there's no capacity for remodeling or for increasing blood supply. And so we have more injury rates. For bone, bone has to have a balance between building and breaking down. If we only built, our skeleton would be so heavy we couldn't move it. If it only broke down, it would be so weak it wouldn't hold us up. So what the loss of estrogen does to our bones doesn't get rid of bone building, but it makes the balance off. And so we break down at a higher rate than we build, right? And so that is critical. We already talked a little bit about muscle and the role of estrogen in enabling the reproduction of satellite cells, and which are the muscle stem cells that help our muscles stay healthy and actually help us grow muscle. We need, I'm a big proponent of telling people to get out there and lift. We need to continually build muscle.
So talk about, a lot of us, our generation, were scared of weightlifting. We didn't want to be bulky. We grew up in the area of aerobics. Weightlifting was never anything I ever did. One of the things I like to talk about, if I could go back and what I preached to my daughters and what I could tell my 30-year-old self, was stop doing aerobics and pick up some weights.
That's right. Throw the weights around. Mm-hmm. Well,
so what do you say to a 55-year-old woman who's never lifted weights and doesn't even know where to begin?
Yeah. And that is a lot of people. Number one, I'm going to say
a majority
of people are in your boat. Do not let that stop you. I would tell them to, hey, you want to look at other people who are doing it? Find the Wonder Women on this Instagram, all mere mortal women who have used weights to reconfigure their bodies and to build lean muscle mass. But what I would tell them first is figure out what your bones are doing, right? Because I want you to lift really heavy. I want you to lift as much as your bones will bear, meaning only 3 to 5 reps for your upper body push-pull and your lower body push-pull. So squats and deadlifts, bench press and pull-ups, as much as your body can bear, but your bones can bear. But you only know that if you get a DEXA scan, because what we don't want to do, I had this amazing patient, 57, doing all the right things. She just lifted too heavy and she broke her hip because her bones wouldn't bear it. So number one, figure out what your bones are doing. Number two, find somebody to help you. Nobody expects you to understand how to do this. The good thing is that there's lots of apps now that will show you the motions. They'll take you from getting off the couch through the first phase, which is just about mobility. It's just getting your ankles and your knees and your hips and your shoulders to move again through full range of motion. And then once they do that, then it's time to start lifting weights, right? So it doesn't have to go from 0 to 60.
So I have a lot of patients who love their Pilates and love their yoga. And that's all they're doing. How would you counsel them?
I think that's fine because that can be very relaxing. It can be very good for stretching. But that is not what midlife women need. We must build some muscle. You can do that for relaxation. Why don't you make that the second class of the day? Go lift some heavy weights and then get on the Pilates reformer, or go settle down and get your cortisol levels down on a yoga class. But there's just no way that you can't lift weights if you want to be as strong as you can. Because what do we want when we grow old, right? I want to do everything I want to do. And I have to prepare for that, right? It's not going to just happen. What happens is all the things we've talked about if we don't pay attention. I'm going to be so mad if I can't do what I want to do at any age.
So a lot of the argument or pushback I'll get, especially on social media, not with my patients, is this is a natural process. Why are you messing with it? We're meant to do this. And like you're saying, if we just let nature take its course, what are we looking at? And we don't actively pursue the counteracting the musculoskeletal changes of menopause. What's going to happen?
Well, I think you can go to any mall in America and see what's going to happen. We're going to gain 50 pounds. We're going to, instead of walking somewhere, we're going to shuffle somewhere. Our hips are going to hurt because we've gotten so much arthritis that we can barely move. We're therefore going to get out of breath. I mean, just look around. 70% of people in this country do no form of mobility every day except getting out of their chair, getting their car, and going to work. Nothing. So there's plenty of examples. And I say this every day to my patients, not in a flip way. Listen, I'm not trying to rule your life. You can choose to live like that, but it is an active choice to abandon your health when you know what can make you healthy, vital, active, joyful. We know it's not rocket science. Anti-inflammatory diet, protect our sleep, manage our stress, consider HT, move some weights around and do base training with zone 2. And most of this is your toolkit, right? I mean, we know what works, but it's a decision. And when people come to me and they say, oh, I can't, I don't know. I said, listen, because I'm kind of a coach with my patients. I've been doing this 30 years. You cannot out-excuse me. I know the answer to every excuse you're going to give me. So you just bring it on. I'm going to tell you. They come to
you, if you don't want this to happen or you want to feel better, this is what you need to do.
Yeah.
Okay. So what is arthralgia? Let's talk about definitions.
Yes. Arthralgia is total body pain. Your whole body hurts. And then of course, specific joint pain. When you're injured in an accident, jump off something, you usually hurt one joint. Arthralgia is everything hurts, right? And you and I have had this discussion, and maybe I haven't read the research you have, but I had this hypothesis that the total body aching that shows up in midlife women is not fibromyalgia. It is arthralgia, can be treated with hormone therapy. And I know you've read the paper, so
yeah, that there's some smart people out there that usually, fibromyalgia in our, is a diagnosis of exclusion for everyone. They rule out X, Y, and Z, rheumatoid, whatever. And then, okay, well, it's got to be that because nothing else is left.
Yeah.
Well, because there was this huge gap of knowledge on estrogen deprivation and what it does to the musculoskeletal system, now people who are on top of this are thinking there's a significant percentage of women who are mistakenly being diagnosed with fibromyalgia who actually just have our musculoskeletal syndrome of menopause. And the first line of therapy should be a trial of hormone therapy to see if she gets better. Now, again, I haven't seen the outcomes of those trials, but I can tell you in my clinic, and you can discuss your clinic, I'm seeing people shocked beyond all belief, not all, how much better they feel joint, muscle aches and pains wise with hormone therapy versus without it.
And you know what? I got so desperate to help my women around here because they would all come to me, the orthopod. It's a little interesting, but they've heard me on social media. And I just couldn't in good conscience send them away to try to find somebody that would help them. So for women with simple histories, histories I understand, not deep breast cancer marker, simple histories with none of that. I prescribed transdermal estradiol, and within 2 months, a woman wrote me today. She's like, I need you to refill this. My life has changed forever.
It's
Yeah.
amazing.
Yeah.
Okay, so let me get your top tips here. This is the elephant in the room, frozen shoulder. This is what brought me to you. I did not know so much about musculoskeletal syndrome of menopause. And then, what opened my eyes to it was enough people on social media asked me by the thousands. And finally, I started digging around, found a couple of papers, posted them, and the internet blew up with people saying, oh my God, oh my God, oh my God. So talk about frozen shoulder. What is it, the encapsulitis? And then what are your top recommendations as a clinician to treat it?
Yes. So frozen shoulder is that thing where out of nowhere, you didn't bump it, you didn't throw something, your shoulder just starts hurting. And then within a few days, you can't lift it very well. And you definitely can't put it behind your back to do your bra, right? This is all painful. Yeah. This is all painful. And you're thinking to yourself, what did I do? I didn't do anything. And then it hurts to sleep on. And what's happening is as estrogen drops, our ability to control the pro-inflammatory cytokines, all those chemicals in our body that circulate, diminishes. And inflammation, the shoulder is incredibly sensitive to inflammation. The other group that gets adhesive capsulitis is diabetics with high blood sugar, because they're just a fireball of inflammation, right? So in our shoulder, there's the outside skin, then there's the big muscles that we see in the gym, like the deltoid. And then below those is the rotator cuff, which you never see, but it's really important. And below that, deep inside, covering your bones, is something called the capsule. It's like an orange rind, but it covers the bones. That is incredibly sensitive to inflammation. And when that gets inflamed, it starts shrinking. So frozen shoulder is adhesive capsulitis. It's inflamed capsule. It starts forming fibrous tissue and shrinking. You can't move your arm. But what should you do? Number one, recognize it early. Just don't ignore it for 2 weeks. Grab a wall, walk your fingers up a wall as high as you can, move your arm
Like
up.
this?
Yep. Grab it, just put it on a wall and walk your fingers up. Move it to the side. If you get I don't have a broomstick here in my office, but if you get a broomstick and you just push it out yourself, or get a towel and pull it behind your arm, because what you don't want is just to let it sit. We want it to move. Number one. Physical therapy is a great thing. Get somebody to help you. In most states, you can have 12 visits of physical therapy without going to a doctor first. So get on that soon. Just show up, tell them your shoulder doesn't move, they'll help you move it. If that doesn't work, there is good evidence that a steroid injection into the shoulder can decrease the inflammation enough to get you over the hump to move it. I am not an orthoped that loves steroids. I barely use them. But in this indication, if I'm just trying to get you moving again, I will do that, because frozen shoulders can take 2 years to unthaw. 2 years, right? The other newer treatment that we're doing now is to take whole blood out of your arm, spin off 5 billion platelets, which contain all of your growth factors, and inject it, because that has a profound anti-inflammatory effect. And then finally, when nothing works and you're miserable, actually there is data that an orthopod taking you to the operating room, putting you to sleep, and manipulating you under anesthesia to break up the adhesions will get you a 50% head start. We try not to get there, but if you've been frozen for a long time, sometimes it's worth it.
Okay. What can you do about arthritis?
Yeah. Oh, so many things. So
I'm talking about osteo.
yeah, osteoarthritis, so many things. Number one, I want every single person listening to consider their decision to go on hormone therapy, and early, and continue until you die, so that your cartilage is well preserved. I want you to make the decision. I want you to read whatever you have to read to feel confident that you're not making a decision out of fear. Number one. When you decide to take HT, you're going to find that the receptors on your cartilage are now filled again, and your matrix will be better. But what if you already have arthritis? Well, number one, cartilage is very sensitive to load. The joints bear 5 to 7 times body weight. So getting a handle on the body weight we accumulate is critical for your joints. Even 10 pounds decreases the pressure across a joint almost 100 pounds. So it's not about the little black dress losing weight or building muscle. It's about joint protection, right? And many, many other things. It's not about going to your high school reunion in the same dress you wore to your prom. Not. So there's load management. Number two, there's anti-inflammatory eating. I mean, all they have to do is read you and know how to eat foods that are not going to cause you to be a fireball, right? That is critical for arthritis. Number three, I do not love steroids. I only use injections like that if people are in raging pain and they can't get through it. I love things like platelet-enriched plasma, which has great data. It can give you relief for up to 2 years as you are building lean muscle mass, right? We don't want our joints to pound together like this. We want our muscles of our butt, our core, and our hips to be shock absorbers so that we land better and don't get the jolts. And then after we've been through anti-inflammation, hormone therapy, anti-inflammatory diet, managing the load, using biologics, all the things we just talked about, if your arthritis gets so bad that you see your activity in your life sliding away from you, consider a knee replacement. It's hard for 3 months. It will give you your life back. It's one of the most successful surgeries orthopedic surgeon will do. Nobody wants to have metal, but if you have a choice between sitting in your chair the rest of your life or getting active again, it's something to consider.
Okay. And then we talked a little bit about muscle mass. Can you talk a little bit about protein intake? That's a big hot topic right now.
It is. It is. I think, and I was not fully aware of this for quite some time until I did the deep dive.
Same.
Were you aware of it? Yeah.
You know, the first book, when I do rewrite it, Galveston Diet, we're going to rename it, but I will have higher protein recommendations.
Yeah. Well, it makes a world of difference in a lot of facets, but I recommend 1 gram of protein for every ideal pound. And it can be a lot. I mean, so, you know,
when you say ideal, people are going to write in like, what do you mean?
What does that mean? If you are 5'6" and you weigh 181 pounds, well, that is not all ideal, right? Whatever the ideal for a 5'6" woman is, maybe it's 140. I don't know. I'd have to look. But that's the aim, right? To eat that much protein so that you do not eat your protein or eat your own body.
You don't phagocytize your,
Yeah, that's right.
So your body will, just like your bones, when it's looking for amino acids, it will chew up your muscle if there's none floating in your bloodstream.
That's right. That's right. If you don't feed it what it needs, it's going to survive and it will eat what it has in store. That's why some of why our bones go away. So I recommend 1 gram per pound. So it can be a lot, but it's not that hard, right? So I divide it up over to my meals in a day. I get about 20 in the morning. I do some kind of protein snack around 10:30 at lunch. Mary Claire, if you're in my office, you're going to see me. So stupid. I bring chicken breast from home. I put it on a fork and I eat it like a popsicle in my I'm just going around doing my work. It's just, I'm sorry, ladies, don't judge me, but I get it done, right? Just because I know that any kind of meat the size of my hand is about 30 grams of protein, right? Yeah. And once you start counting protein, you'll know. You don't have to count it all the time. You'll know.
I'll do shakes or different things to kind of help get it in there. I still fast, so I kind of lose that morning protein. So to make up for it, I'm adding extra scoops of collagen, which isn't a complete protein. It's missing 1 amino acid, but I figure I ate enough animal protein throughout the day. I'll be fine. And I'll sometimes do the bars, the high protein rich bars, just to kind of help me catch up and not The way most women in the US eat is almost no protein for breakfast, a little bit for lunch, and then they kind of stack their protein in the evening. And it's going to be way better for you if you separate it out throughout the day. One of the good things that came out of Women's Health Initiative study, it's not it's not all bad, was looking at muscle mass, strength, osteoporosis, and fracture, and protein intake. And what they found was, now this is in kilograms, women who had 1.5 grams per kilogram of lean body mass or greater, which is about 0.8 of what you're talking about versus the 1, had the highest. There's definitely a correlative linear for protein intake and muscle mass and osteoporosis. I think one of the things I want everyone to understand is that musculoskeletal unit acts together. You have strong muscles, you're going to have strong bones.
Yeah.
Now, can you talk about the jumping and the vibratory and those kind of exercises? I see you jumping off of boxes and I'm so curious.
Yes, I do. I do plyo. I jump up and down because the bones have an electrical circuit within their matrix, and that jumping action stimulates and please, PhDs out there, don't throw stones at me, but it stimulates the electrical pathways that cause laying down of bone. The impact, our bodies are so miraculous in rising up to the occasion of what our body needs. And if our body sees us jumping, it knows that it needs to be able to withstand impact and will lay down bone or stimulate the electrical pathways that will then allow the minerals to be laid down into bone. And it doesn't take that many, 20 jumps a day. Literally, I want people to work on their balance by brushing their teeth on one foot every day. And then while you're standing by your sink, just so you're safe, jump up and down 20 times. And then women ask me, does it have to be plyo off a box? No, because listen, I was a naysayer about rebounding on a trampoline until I started reading the fact that NASA uses rebounding on a trampoline to repopulate the bone and muscle for its astronauts. So it's a good way to start.
Awesome. And back to the DEXA. How does the DEXA work? And besides bone density, it can tell us a lot of other things. And sometimes you have to tell the person to print out that part of the report if it's more than just your bone density, but just talk about that for a minute.
So the DEXA scan is a radiographic test that, when it's looking at your bones, compares what it sees in your bones with the X-ray and compares it to a 30-year-old healthy woman. They've chosen 30. It's the last year that we lay down bone as the 0 on the bell curve, right? We're all used to bell curves.
Maximum bone density.
Yeah. Maximum bone density at 30. Anything on the plus side of 0 is good times. If you have a bone density of 1 or more, that's amazing. For most of us, our bone density goes in the opposite direction, -1. -1 is osteopenia. Our bones are getting weaker. -2.5. These are standard deviations on the curve. It's a statistical measure. -2.5 T-score is frank osteoporosis. So that's what the numbers mean for bone density. But what you can also get from a DEXA scan, you can get pounds of adiposity. You can know, if it's a complex machine, how many pounds of fat on your left arm, how many on your right, how many are smothering your belly, how many on each leg. And those are really critical. The words are gynecoid and android, right? And android fat is the appley fat that smothers your organs. We want as little of that as possible. I always say it's better to be a hippie girl carrying your weight around your hips, the gynecoid, because then your risk of metabolic disease is 5 times less, right? So you can also get those numbers from a DEXA scan. The last number that I find helpful for my patients is the not only percentage, but actual pounds of muscle. Because I track that in myself. I track that on people I take care of here, because I want to know how much muscle we're building. And I certainly want to know if that's decreasing.
So I have an in-body scanner in my office. Doesn't do bone density. I always recommend to go get that, but it does do muscle mass, visceral fat. and then subcutaneous fat. So it's helpful for tracking for my patients to see
So
their
important.
success. A lot of them come in and they're so focused on the number on the scale. I had a patient today who gained 2 pounds, but she'd gained 4 pounds of muscle and lost a pound of fat. And I was like,
That's great.
you're amazing. And
Yeah,
she was
really
also
great.
freaked out that she gained weight. And I'm like, the number on the scale does not represent your health ever.
She must have fit differently in her clothes.
She did. And, she just was having one of those moments where she was so focused on that number and that she failed somehow because the number went up instead of down. And she was doing all the things, eating the protein, doing the exercise, So when she saw it digitally, she was like, oh, okay. And I could see how much less fat you have. And then it made sense to her.
Oh, good.
So let's get to, go ahead, Jamie.
Oh, I'm sorry. My dog started barking right as I came on. Excuse me 1 second. I'm going to make her stop and then.
All right. So we are going to get to our Q&A's part of the webinar. So it's still not too late. Go ahead and put your questions in the Q&A.
And we will cover as many of them as we are able in the time we have remaining. This was a great question. What's the best type of specialist to see for osteoporosis?
So if you break your hip, you must ask your traumatologist, or you break your wrist or any bone, say, listen, it's time for a DEXA scan. I can't break again. The number one predictor of future fracture is past fracture, right? So do not let the opportunity. So that could be your orthopod. You can ask your primary care for it. I asked my OB the first time I got it. She's like, yeah, I'm writing everything else for your health. Write the DEXA scan. Your endocrinologist can do it. Any doctor can write it. It's just a matter of getting someone to interpret it for you.
Okay. So if you are, and what is your treatment protocol? So say you've been diagnosed with osteopenia, what recommendations would you in general give a patient?
I will give them all the things we've talked about. We are going to do a little bit of impact so we get our bones laying down. We are going to eat protein. We are going to build lean muscle so that our bones are pulled upon and stimulate them to lay down more bone. I'm going to make sure their vitamin D is high, their magnesium, I don't take zinc or boron myself, but those are other helpful minerals out there for this. But I just make sure that their big ones are up to speed. And then for an osteopenic person, it's really an ardent discussion about we cannot let this progress. We have an opportunity right now, and we have to take it seriously.
Right. Agreed. So piggybacking on that, can you talk about calcium? There's a lot of debate in the literature about the safety of calcium and supplementation versus getting your calcium from food. Can you discuss your thoughts on this?
You know what, for years, I went with the standard line. If you're less than this age, give 1,200. If you're more than this age, give 1,800, divided into 600 milligram doses, blah, blah. Well, I don't do that anymore because there's so much controversy. I can't find data, and please correct me because you would know this. I can't find data that says if you don't take it, your bones are going downstairs in a handbasket.
So what I've read is that the oral calcium supplements put you at risk for kidney stones and possible, the cardiovascular surgeons are saying absolutely not. They feel like it's making the calcified plaques worse in the arteries. But if you are getting calcium from your food, at least 1,200 milligrams a day, you are less risk of fracture. So this is one of the things I'm not recommending routine supplementation, but to really push to get your calcium from food.
Yes, I'm glad we agree.
Okay. Jamie?
Another question, muscle recovery. It gets difficult. I have this problem, and I know others do as well. Aside from, obviously, you've mentioned HRT, but are there any supplements, amino acids, anything like that that you might recommend to aid in muscle recovery post-workout?
You know what? I am a big fan of creatine, 5 grams a day. It has many muscle and brain benefits. So I do that every day. the 1 gram or more of protein per ideal pound is critical for recovery. And I like people to resupply their bodies within 30 to 45 minutes after a workout.
Fantastic.
Okay.
Thank you. We have someone who's a Pilates instructor, and we touched on Pilates and yoga. She's asking what she can do as, someone in service to people in menopause to help support them. What recommendations might she make? And it's just an interesting crossover with what you've said. So curious.
Well, I think Pilates instructors have a very unique opportunity, depending if they're on reformers or in a class, to meet women one-on-one in a safe environment to educate them, right? I think we have to do more than Pilates. I think we have to lift, or at least lift our own body weight, right? If we can't lift iron, lift our own body weight. But I think she has an amazing opportunity 3 times a week, probably, with people who come and do Pilates with her, to educate every day, have resources. Maybe she has a library of books, or she prints off a QR code of, these are the trusted sources I have, because people don't know where to go.
Mhm.
They're lost.
Don't. And there's so much conflicting information out there.
Yeah.
Right.
Let's see, a lot of questions on hormone therapy, but let's see, are there any home scales that were actually somewhat accurate to report muscle fat hydration? Seems like a gimmick. How do you weigh in on this?
Well, I can't afford to have an in-body deluxe in my house.
Yeah.
So when I want to know that, I go to the one that's in my building or in my office. But so I just have a scale in my house. And the only reason I ever get on it is to know what I'm doing, right? Oh, what's that extra 5 pounds? Or more importantly, oh my God, I'm down 5 pounds. I'm not down in muscle. Am I so dehydrated? Because to know how to replenish, we should know the amount of fluid we're losing overnight, for instance.
Mm-hmm.
So every pound of that you lose overnight is actually not real poundage, not muscle, it's water, right?
Water.
Yep, it's water. So you just need to hydrate back up so you function well. I guess I don't have an opinion. Do you?
So I've got the InBody at home, and because they send me this stuff, and I've got like the cheap one, the $100, not cheap, $100 one. And so I've done all these comparisons, and I'll go to the office and do it. The InBody at home has a little like wires that come up where I can hold my arms out. What I think those are good for is looking at trends rather than absolutes. Do I think if it says you have 24% body fat, you have 24% body fat? No. But what I think it's good at looking at trends over time. I don't recommend people weigh themselves for weight loss every day. That's just a mental beatdown. But I think for people who are trying to track percent fat or muscle mass, it's a cool thing to do once a week, maybe, to just look to see how you're trending. But it's, the most accurate thing you can do is a bone density, is the bone density scan. But I can't afford, that's a $60,000 machine. And so the InBody, like hospital grade scanner, is what I have. And so that's what I use for my patients in the office.
Yeah.
Okay. For those where HRT truly is contraindicated, can you touch on some of the things you've mentioned, strength training, etc.? Dr. Haber, you have your toolkit, but perhaps between the two of you, you can touch on a few things that those who truly cannot do HRT, what they might consider to help with these musculoskeletal issues.
Mm-hmm. Well, I think everything we've talked about, anti-inflammatory diet, protecting your sleep, adequate hydration, building lean muscle mass, low heart rate based training followed by sprint intervals to stimulate satellite cell production. All of those are still open to you, all of them, even if you can't do HT. It's one, although very important. I think it's very important. If you can't, all is not lost, right, Mary Claire?
Right. And then the last few minutes, can you discuss the different pharmacologic options available for osteoporosis?
You know what? Yeah.
Max, Prolia, just in general, so people have an idea.
You know what? When my patient has a bone density of minus 2.5 or more, when they are musculoskeletally frail, I send them to an endocrinologist that I trust.
Yeah.
Because I can't be an expert in everything.
Mhm.
So I send them to somebody whose entire field and who is like-minded, right?
Mhm.
So I vet everybody I send my patients to, and that is the best I can do for them.
Yeah, that's great. Because some of these medications have lots of side effects. They
Yes.
can't be very powerful, but really nothing works better than estrogen therapy. And so if a patient isn't on hormone therapy, I'm like, you really should start here first. This is the best. But if they have absolute contraindication, again, I'm the same as you. I will continue them on those medications if they come in and they're doing well. For new starts, I'm pretty much sending them to a trusted endocrinologist because the workup is so extensive, the follow-up, and some of them are injections, which I don't have a transfusion center, you know.
Right. And you have to do liver labs. It's
Yeah,
complex.
it's very
So,
complicated. Mhm.
Fantastic. We're coming up to the end of our time together. For those watching, you will receive an email. I believe it's set up to go out tomorrow with a link to our new free community, the Pause Life community. The replay of this will be housed there. You'll be able to find that along with a bunch of other resources to help you with everything that you're experiencing through this menopause journey, as well as community and support, which goes so far, knowing you're not alone.
Dr. Wright, how can they find you if they want to learn more about your books, your programs?
Right. So everything I have is under Dr. Dr. Vonda Wright. So whether you're on Instagram, Dr. Vonda Wright. My webpage is Dr. Vonda Wright, and it has my surgical practice. It has my women's health interest and speaking on there. And then I have a lot of videos on YouTube that for a while was pretty dormant, and now I'm repopulating. So you can find my body of work in those places.
Awesome. Okay. Well, thank you so much for joining us and answering all the questions and educating. I learned stuff today too. So, and we look forward to having you on the cruise in January.
Yay!
So
I'm
she will
so
be there
excited.
live. And again, you'll be able to catch that we'll have a live video option. If you can't come on the cruise with us, we want to make sure everybody has accessibility to be able to learn from Dr. Wright and the other physicians coming and experts coming on the cruise with us. So
Wonderful. Thank you for having me.
okay. Take
Thank you
care.
both.
Bye-bye.
Bye.